thank you for coming. We're very delighted and flattered that so many of you turned up on this beautiful morning. I'm just going to give it a little welcome and kind of set the scene for the day, and then we're going to talk about these specific topics which you have outlined in front of you. So we're going to start with, I'm going to dive straight into this and give you a few quick rules about backs and back pain. The first thing, I'm going to start right from the beginning. Protect your back. Okay, everyone here, a lot of people here have back pain. I myself have suffered from back pain, and the most important thing you can do at all is to protect your back. And there are essentially three main rules to this. The first one is don't fall over. Okay, now we're at the end of the slippery season. The number of my patients who go down and hurt their backs after we've been working and working is quite a large number. So don't do that. The second thing is don't lift something. If one of your neighbors or your friends invites you to help them move house or to move their piano, just make an excuse and just don't do it. And the third thing essentially is if it is in your own home and you have to deal with this issue, you should basically outsource all those activities to your other half. Okay, so try to avoid doing them yourselves. And to that end, I just wanted to say that I practice what I preach, and I want to just illustrate a couple of points on this. This was a study that was done which talks about how different postures which stress your back. Now, about a year ago, my wife and I decided we wanted to have a patio in our very small backyard, and I was very gung-ho about this and ordered a couple of tons of these huge big flagstones. They're beautiful, and they arrived and they sat there for about a month, and I can procrastinate as well as the next man, and occasionally my wife would hint that maybe it was time to get working on it. And I kind of kept putting it off, and as it happened I gave this presentation in which I brought up this slide which essentially shows a few things. It shows that this was back in the glory days when there weren't any medical ethics when it came to doing these sorts of things, and you could just do this on medical students, but you put a pressure transducer in somebody's disc and you put them in different positions, and what it says is when you're standing up we take that value to be 100, and as you lie down, not surprisingly, it relieves pressure on those discs. But as you move up the chain and you start getting to here, you end up in a situation where you're really stressing your back. So anyway, the stones sat there, and my wife would occasionally hint. And the more I looked at them, the more I realized that I was going to be in big trouble here. So one day she came in, I was sitting on the sofa, and she mentioned that maybe now was the time, and I hadn't had my laptop, so I flipped open this slide, and I said to my wife, I sat her down, I said, look, this is the situation, and I really can't risk my back. And I suggested that maybe she would be happy to do the moving of the stones herself, but that I would take more of a kind of maybe a project management, maybe a kind of design role. I wasn't going to pull out completely. So she let fly a few choice Anglo-Saxon terms, which I don't recall from our wedding vows, and stormed out the house, slammed the door, and actually started digging away in the garden, getting things done. I, meanwhile, adopted this position here. I was moving into back protection mode, and I think I may have fallen asleep, and a couple of hours went by, and then I heard the door fly open again. She flies into the room, the door slams, she passes me by, another tirade of unmentionable phrases, and up she went upstairs. Slam, slam, slam. By this stage, I was in maximal back protection mode down here. I gradually worked my way up through here. I risked this one just to get to here. And then I went outside to admire our new patio. And now my wife is very sporting, as you can imagine, and as you can tell, has the strength of an ox, but she made some interesting design choices. And at this point, I realized I need to take a slightly more holistic view of treatment of back pain, and And which is why we have today our panel, and we're going to go through this. So simply lying on the sofa avoiding work is not sufficient, apparently, and there are other options for us. So we're going to go through a few quick introduction. We're going to talk about the common causes of back pain. Ian's going to talk a little bit about physical medicine and also how to access and how to get into back and spine care program that he actually set this up 10 years ago. I'm going to talk a little about spine injections and something called neuromodulation, and then Steve is going to talk about surgery and when surgery is needed. We'll have a few questions at the end. We'd like those questions to stay as general as possible. If you have specific questions about yourself, either make an appointment with us or we can talk afterwards. And then afterwards we'll go outside and you can meet some of the people who provide spine care in this area. So to sort of bring this all together, this is a beautiful picture of a very healthy spine, color-coded. You've got the cervical, the thoracic, the lumbar, the sacral, and then the coccyx at the bottom. And what I tend to do is, as I say to people, you know, if you take something about the size of your cell phone, which incidentally should be off for this, and you place that over this area of your back, like that. Almost everything we deal with takes place in this small zone at the base of the spine. Large amounts of everything that we deal with takes place in this very small area, which should make it very nice and simple and easy. But of course, it isn't that easy. And if it was, we wouldn't be here. Because under this, there's all these things: bones, discs, joints, nerves, muscles. And I put skin there, and I put it in parentheses because there's just one thing I want to say about skin. Every 6 months or so, somebody comes in and they have something that we can't quite explain. And sometimes you think, well, is this shingles, right? And my rule of shingles is, if you think it's shingles, you treat shingles, okay? So if you have any thoughts, if that word enters your head, you treat it. I'm not going to say any more about the skin. Essentially, when we deal with treatment of pain, there are 4 buckets. These are physical medicine, which we're going to talk about. Medication, which I am not going to talk about today, and it's a long and rather dull subject. We're going to talk about injections, neuromodulation, and surgery. That is it, okay? On top of those things, there are other sort of things around the outside. Nutrition is very important. Psychological support is very important. And alternative therapies that are out there that can contribute. But we're not going to go into those. We're really going to talk about these 3 big buckets of pain treatment. Okay, so first of all, Ian Paskowski is the medical director of the spine care program at Beth Israel in Plymouth. He attended New York Chiropractic College in Seneca Falls, New York, and completed his residency at National Naval Medical Center in Bethesda, Maryland. Dr. Paskowski participates in research studies focused on population-based management of spine-related disorders. Prior to graduate school, he attended Providence College, where he was a defenseman and captain of the NCAA Division I Friars. He has been with us since 2006. And the fact that he didn't want me to bring up was that he was at one time a professional hockey player. Dr. Stephen Leckie is the orthopedic spine surgeon at Beth Israel in Plymouth. As part of the Plymouth Bay Orthopedic Group, which I know a lot of you know. He specializes in complex neck and back surgery. He obtained his bachelor's degree from somewhere called Harvard and his medical degree from the University of Massachusetts, completed orthopedic residency at University of Pittsburgh. During his residency, he completed a spine research year, was the orthopedic and trauma attending before he returned to fellowship. He did a spine fellowship at Emory University before joining us here in 2014. As Ian said, Steve is the best looking guy in spine, and the nurses often make this equivalence. I'm also going to talk, I trained, I'm an anesthesiologist by training. I trained in England. I came here following my good lady wife, and was encouraged by Uncle Sam to repeat my residency, which I then did. And then I did a fellowship. I trained my residency at Tufts, and I did my fellowship at St. Elizabeth's. And I'm here. I've been here for 2 years. Hockey hero, superhero, and the guy who sounds like the paint. All right. So that's my little introduction. We're going to zip along. Ian, I'm going to get you up here. We're going to start by talking about physical medicine.
Good morning, everybody. happy holidays, happy Easter, Passover, and whatever else might be celebrated over the next couple of days. It's really amazing to have so many people show up for our event this morning. As Ben alluded to, we started this 10 years ago. We actually did one of these conferences 10 years ago, and we had about 70 people, and that was the benchmark for the greatest number of people to attend one of these events. So now we have eclipsed that number. So our new benchmark is our attendance today. So thank you so much for coming in. I'm going to try to get through this stuff really fast, not repeat too much of what Ben has said, but try to give you some information. And again, any questions you have will be available at the end. So my name is Ian Paskowski. I've been a medical director here for 10 years. And my job as medical director is not to tell, not to tell anybody how to practice, or I'm definitely not going to tell a surgeon how to do surgery, or an anesthesiologist how to do injections, or a physical therapist how to provide therapy. But we want to kind of direct patients through care so you can get the right care at the right time. That's when we started. I think Nancy Gage, who is here someplace, where's Nancy in the back? Nancy Gage and I sat down 10 years ago to try to put together a plan to organize spine care in our community. And I'm very proud to say we're still going. Nancy still looks great, and I am balding, and my jacket barely fits me now, but we're still going. So recently a study came out in the Lancet, and I'm not going to allude to studies too much, but it was a three-part study on back pain and where we stand now. And it's amazing. The first real studies in back pain came out in 1993, which is the AHCPR, I think, guidelines came out, I think it was called. And where we are now is really not a ton different from where we were in 1993. Our people are better, our training is better, but what we actually do to patients hasn't changed a ton. But what has changed is what we know about controlling back pain and what you can do to avoid back pain. First of all, we're in a room with 100 people, and it's Saturday, beautiful Saturday morning, and despite what Ben said, he's the best looking guy in medicine, and Steve's the smartest guy in medicine, but you're not really here just to look at them this morning. You're here because you have back pain, and everybody experiences back pain in their life. We used to think it was 60, 80% of the people in the world. Now we know it's almost 100% of the patients will experience back pain in their life to some degree. And most of the studies up until 10 years ago were done in high-income countries, United States, Canada, Western Europe. But now we know, as we're starting to look around the world, all the world's populations suffer some level of back pain. Doesn't matter economics, social status, race, gender, everybody suffers back pain. So if you're here because of back pain, which I'm guessing you are, you're in good company. And we're getting better at it. But going forward, what can we manage? From a physical medicine, from a non-interventional perspective, what's important about managing back pain over time? Number one, diet. If you eat healthy. Exercise, some level of exercise. And it doesn't matter, there's specific things to do for specific conditions, but in general, if you like to walk, walking is a great exercise. If you like to do yoga, even emotional exercises, crochet, reading, sitting in groups and talking, anything you do that involves you in a social activity that has some level of physical involvement is an excellent exercise to manage back pain or to avoid back pain over time. Smoking, obesity, two activities that socially affect every condition we have in the patient population. If you can set a goal, whether it's a knee pain, hip pain, back pain, to lose 5 pounds in the next year and do that for 5 years straight, that's 25 pounds over 5 years. And if you can do that, I can almost guarantee you'll do more to avoid musculoskeletal conditions, plus help cardiovascular disease, type 2 diabetes, than anything else we can do. Just that simple idea of losing 5 pounds a year. And then active coping strategies, and that's where we come in. And one of the major advances in back pain is that we know patients who can understand their condition and aren't afraid of their condition, and that's where we kind of come in. The more you understand your condition, the more you can do to know what to do and what not to do, what type of pain to be afraid of, and what type of pain to be aware of. So if we can work with you and give you a simple set of activities that when you have back pain, if you've been to see us, most people, if you have back pain, the first thing to do is stand up and lean back. Try some anti-inflammatories, ice, and try that for a couple of days. Or some variations. If those things don't help it, then we want you to come in and see us or email us and we'll discuss it. But if when you have back pain and you decide I need to move and do something else, that's much different than having back pain and being afraid and sitting on the couch. So that's really, the research has led us to that level of understanding of those simple little things can make the biggest difference over time. What you can't control, 5 years ago I used to tell patients that genetics have very little to do with our back pain. It's just, it's more about activity. But genetics actually do play some role. So you can't really help that. But what you can do is those 5 things above that and try to be active. And then the last thing, as Ben alluded to, is bad luck. You can't help slip and falls. You can't live life afraid to do certain things. So, work on some level of coordination also. So, and then from us, as far as the spine care pathway and ideas, what you don't know is what we can help you with and get you to the right place at the right time. So the global back pain, we went into this a little bit. I won't bore you too much, but it is a significant event that affects almost the entire population of the planet. That says a lot. It says a lot. So as patients, so you have an event of back pain, and it's not going away with anti-inflammatories. You saw your primary care doctor, and you're just kind of sitting around. So you look in the phone book, and this is really where you are, right? You're standing in the middle of this sea of providers. You have pain, you have surgery, you have physical therapy, you have a chiropractor, you have acupuncture, you have massage therapy, you have nutritionists, you have hypnotherapy. I think there was a study done. There's 500 different options just quickly for back pain treatment. So what do you do? What do you do as a patient? And as a primary care, I made this slide 10 years ago, the first time I did a lecture, and I call that way. We called this the vortex of hell, because you're the patient in the middle, and the primary care doctor is sitting there. What do I do? And the primary care sends you here, and then you come back, didn't work. Then you go here, then you go there. So what Nancy and I sat down and did, and then sequentially with Ben and with Steve, was trying to create a simple idea, a central place where patients can go, make one phone call, come in for an appointment, and we'll figure out where to go. We'll figure out what to do with you. What's your best option? Put the patient in the absolute center of the equation. Know that our community has awesome resources. I trust everybody in our community implicitly, and we trust each other. But we're trying to figure out where you need to go at that point in time. What happens a lot of times, you go into different environments and you go there and spend 6 weeks. Really, after the first week if the intervention is going to help or not. After the first few treatments, this is getting better or it's not getting better. It doesn't take 6 weeks to figure that out. And what we've developed as far as a care pathway is trying to get patients where they need to go at the right time, as fast as possible. This is our roster of people here, and this is, these are all the different services that we offer, and it's extensive and it's thorough, but if you go to any hospital in New England or in the United States, they have the same roster of providers, right? So actually what you have does make a difference. It's how the providers interact and how the people communicate and how the patient can navigate through this group of people. And I can say with great confidence and honesty that and actually it's been studied and actually replicated across the country at probably 20 different hospitals now and hospital systems, that how we navigate patients through our system, how we have access, and how the patients get to where they need to be at the right time is the best way to do it. And just, not that you need to understand all this, but this is our simple algorithm for managing back pain, managing patients. And there's no place on here is the name of an actual provider. It's a collection of decisions that we've all agreed on how to process patients. So it doesn't matter. The easiest way to access it is to call 508-830-6991. It's the same number we had 12 years ago now. But whether you see Dr. Moor, Dr. Leckie, Nancy in physical therapy, you see one of the PAs, you see anybody in our spine care program, you're going to get the same exact evaluation, and you will almost invariably come to the same decision, and you'll be in the right place at the right time. Okay, it's consistent, it's thorough, and patients move so quickly through the system. Just one example of that was a few weeks ago. A patient went to the ER, early 40 woman who had about 6 months of back pain, but one morning she reached forward, picked something up class, and just felt immediate back pain. Went to the ER took an x-ray, there was nothing broken. She had some pain, but no real, well, red flags to admit the patient, so they referred it to us. She was seen in our clinic that afternoon, and she had some other findings, and there was some other concerns, so we ordered the MRI that night. The MRI come back, and the woman had a very large disc herniation. So it's not an uncommon finding, but so that's 10 hours from the time I went to the ER to getting the MRI done. So the radiologist actually texted me, said, look at the MRI, it's significant. So then I said, okay, big disc, patient's in lots of pain, we want to move this forward. It was a Thursday night, so I wanted to get done before Friday, so I texted Steve, I said, hey, can you check this patient's imaging out? It was done this afternoon, it's a big disc. So Steve texts back, yeah, I'm in the airport, but give me 2 seconds. So Steve in the airport pulled his stuff up, looked at the image, says, yeah, it's a large disc herniation, how are her symptoms? Text back to him, she's stable. He said, okay, call Ben, see if Ben wants to do an injection first, then I'll see her early next week. So I called Ben, he said, yeah, okay, yeah, imaging looks good, yeah, we'll get her in Monday for an injection. So just that trust, and I know that sounds simple, but the level of trust that we have working amongst each other and together, we trust the evaluation process because we know what we've done, we know what's happening, we have the imaging done all in the system. So in 3 days, the person has been evaluated essentially by the case has been evaluated by 3 people, plus the physical therapist looked at it also. She had the procedure. Now, like less than a month later, she's almost 70% better. She's in physical therapy, and she's probably going to avoid surgery. So that's how quickly we all work together. And that doesn't happen just because we have a thing that says we do it. It happens because we all work together, and we've agreed to work on this process and agreed to understand how we want to work together and assess patients. So I want to talk to you quickly here, the next 9 minutes, about acute low back pain. And it's the most common thing we see in the conservative care end of the program, but it's so painful and it's so disabling, and it's something that the patients, people are afraid of. They go to the ER for this condition. It's something as common almost as the common cold, but nobody goes to the ER for the initial onset of the common cold. So the onset can be 2 things. It can be immediate, where you actually have an event that happens, which is actually more dramatic but less common. Usually the onset's a little bit slower. Most recently, the onsets were related to the shoveling the silly heavy snow we had. I mean, how many people here shoveled one day, did okay, a little sore, the next day they got up and they just couldn't move, right? You're stuck like, you're walking like this, or you go to stand up and you start unrolling yourself, breathe for a second, and then you stand up. Or the classic one is when you go to get up and hopefully the blue board on the wall works well because you almost put your hand through the wall pretty hard. Nobody's had that? So that's what acute back pain is. Usually the back pain's right in the low back. It can radiate down through the buttock, it can go across the back, it can go up the back. Usually it doesn't go below the thigh or the knee. That's a different type of condition. Symptoms, the mild symptoms are more annoying. There's a type that you can kind of walk through. It feels better the more you walk. Take some anti-inflammatories, ice, some exercises you might have learned from before, and it kind of goes away. Moderate to severe acute low back pain is the type that patients sometimes go to the ED for. You go to the emergency department because it hurts so bad. Or, I mean, when I had it, gosh, 7, 8 years ago now, I spent a good 10 hours on our breezeway floor with the kids just avoiding me as they walked past me because I just was stuck on the floor. Thank God I had friends in high places who came and gave me a shot in my butt, and I got off the floor eventually. But those are the levels of acute low back pain that you can experience. When it lasts for a couple of days, symptoms might include greater pains and movements, the transition from seated to standing, things like rolling in bed, getting out of the car, and first thing in the morning, it's like takes an act of the Almighty to get you to move. Right? Now, maybe your significant other is trying to push you or pull you, but not do too much because then it kills, and you get mad at them when they try to help you too much, right? So it's a remarkable condition. So the common causes of low back pain are really, as Ben alluded to, in that area in the low back that's big enough to fit a cell phone on. So we have joints. Facet joints, what's the joints in the back? I'll show you in a second. The disc, the space, the spongy thing between the bones. The sacroiliac joint. And then secondary in reaction to the sprain, you have muscles. So when you injure these joints, you need to, why does it hurt so much? These joints aren't really too big. These are the facet joints are back here. This is looking from the side. Looking from the back, the joints are here, and they're kind of like two plates. If you can imagine two Frisbees up against each other, and they're really concave like that, and there's a piece of cartilage like the knee joint, you have that, and they kind of slide back and forth like this, and they go back, they go back. As you bend forward, they open up like this. As you go sideways, they go like that. I don't know if that shows really well, but they're pretty small, but they provide support and stability and allow you to bend, lift, twist, and all that type of stuff. When you injure, they're made out of the similar material to like when you sprain your ankle. If anybody ever sprained their ankle and it hurts so much you think you broke your leg, you go to the emergency department, you go to your doctor, they take an x-ray, it's not broken, but what do? We give you an air cast, we give you crutches, anti-inflammatory medication, tell you to stay off it for 2 weeks, right? And slowly start to move things again. So that's your ankle, and we can kind of mentally understand what the ankle is. It's distal, you can elevate it, you stay off it, you put it down too much, it hurts, but it's something we can kind of process. You do the same thing to a very similar tissue in your back. First of all, you go to see us and we tell you just suck it up, keep going, you'll be fine, right? But it hurts, and it's in your spine, it's deep, and it's next to some very vital other neurologic tissues, and it just hurts. But the reason it hurts is it's the same pain you have in your ankle, it's just in your back, and it's debilitating. So the reason it hurts is the joints have a covering called a cartilage, and that's the joint capsule. So as you bend, and it has a limited amount of motion, but if you ever step, the idea is like if you ever think you're stepping on the bottom floor of the cellar steps carrying laundry, but you really, either you think there's one more step or there's no more steps, but you just misstep. And your body is thinking one thing's gonna happen, so it tenses, but that thing doesn't happen, and your body all of a sudden kind of freaks out and responds very quickly. So that's how you sprain your ankle, but that's also just how you sprain your back. The joint buckles, and it goes too far or too short, and it hurts. So what happens is as that joint sprains, it starts to expand and creates pressure. So if you're very still, this can be a disc or the joints around the facet joints, as it expands, it creates pressure. Now your body wants to stay still and your muscle spasms to keep it still, but then you go to move and you change that pressure. It's like squeezing a balloon between your fingers, and as that pressure increases, that gives you that sharp, sharp pain. So in the acute phase, we want you to move, but we want you to use anti-inflammatory medications. That's why we want you to use ice. Things to calm down that swelling. As that swelling decreases, your pain will decrease in these acute pain situations. Does that make sense? That's the idea with swelling. That's the idea. That's why it hurts. It's not the whole area swollen, but this little area that's very encapsulated starts to expand. So the anti-inflammatory medications and certain things we can do will push that swelling away. And for activities, this is the sacral. I got ahead of myself a little bit. The sacroiliac joint. If you put your fingers in the dimples of your low back, those are the two sacroiliac joints. So more commonly with sacroiliac joint pain, if the pain stays on one side, and is a little bit below your spine into your buttock, and you can press on the pain and say, yeah, that's my pain right there, that's more likely your sacroiliac joint. Same idea, same type of condition. Whether it's the SI joint or the facet joint, from our end of things, the treatment doesn't change a ton. If we're going to do an injection, then part of the injection process is to figure out, is it the SI joint or facet joint, so we can target that area if the pain doesn't go away with normal conservative care. So the anti-inflammatories, ice, pain-relieving positions, and in general, the way that we evaluate, whether it's PT or chiropractor or any Dr. Taran in physical medicine, the way to best treat patients and the way to get you all to do things that we want you to do at home is that if what we give you relieves your pain. So even if you forget to do it, when you have pain, a lot of people with disc pain, or even with facet pain for that matter, if you have the pain, you stand up and do this, the pain will go away. So you're more likely to do that than if what I give you has no effect or isn't pain relieving at all. So when you have discomfort, anything you do that makes it feel better is the right thing to do. Anything you do that gives you a little bit of back pain, that's all okay. Absolutely, 100% avoid things that make pain radiate away from where the original injury is. So if you do this, and it goes down your leg more, that's not a good thing to do. If you do this and it comes back into the center of your body or away from the leg, that's a positive activity. And from our end of things, what we learned in 15 years of doing this is the less we actually do to you, generally the better you get, which is kind of ironic. Remember that. So just a quick conclusion here. Low back pain is very common, right? Everybody's going to experience something, but how we can help you to manage it is a productive way to go forward. The best way to avoid low back pain over time is to try to be healthy. Try to take common sense approaches to life. And really that 5 pounds a year thing is a great way to approach overall healthy lifestyle. 90% of people will resolve without surgery or even a surgical consultation. So our job is to keep you out of his office. But more importantly, when you're a patient we identify that needs that, we'll get you to see Steve or Dr. Moore that day, or at least look at the imaging that minute. If you have any questions at any point in time, the rest of our common being on this planet, please feel free to reach out. We're always there. Thank you.
Okay, so I'm now going to talk a little bit more about some of the interventions Ian talked about. We're going to talk about these actual injections themselves. We're here again, so we did the first bucket, we're skipping the second, we're coming straight on to the third one. Spine, as we recall, and we talked about what's underneath there, and you remember all these things are under there, and you remember if it's shingles, you treat the shingles, but other than that, we're going to move on. Okay, anatomy, and we need to know a little bit more about the anatomy and the pathology of what's going on in the back. Okay, I'm going to add a little bit to some different aspects to what Ian talked about. There's going to be a few kind of Latin and Greek terms here, and I heard a couple of you are a little bit rusty on your Latin and Greek, so I will translate them. I'm not going to call you out by name, but you know who you are. Okay, so this is the lumbar spine. This is a single vertebrae. It really comes in there's two areas. There's the top bit, which holds the weight, and there's the other bit further down on the screen here, which allows movement and stability, and also protects that hole in the middle there, which is called the central canal. The central canal is where the nerves and where the spinal cord runs down. You'll appreciate we stick them on top of each other. We have 5 lumbar vertebrae, known L1, L2, L3, L4, and L5, not surprisingly. And you'll appreciate when you look from the side that there is also a canal that comes out from the side, and that's called a neuroforamen. And that's where at each level in your back, individual nerves come out, and they go to your legs and down through the buttocks. Well, the first term we're going to really talk about is stenosis. Stenosis means a narrowing, and you can have narrowing in anywhere in your body, but we're interested in 2 types of stenosis. The first one is stenosis of the central canal. So central canal stenosis is when that space that you have in the middle gets constricted, and it can get constricted by a disc bulge, which is coming from this way, or from arthritis from these small joints, or just from additional bone, or maybe the alignment has gone, and you get central canal stenosis. Central canal stenosis typically affects your legs, and it worsens when you walk. Patients with central canal stenosis, when they go to the supermarket, this is the question I always ask them: do you push the trolley and do you lean forward on it? That motion of moving forward opens up that space, and it's pretty diagnostic that that's probably what's going on. The other thing you can have is narrowing of this space, and this will then more typically affect 1 or 2 nerve roots, and that will then give you back pain, but also pain in a reasonably predictable pattern going down into your legs, and we're going to talk a little bit more about that when we get to it. Inside that space, so you saw where that central canal is, there is, so this is now a cross-section through the back, and we're talking about L1, I talked about L2, 3, 4, and 5, and this would be the skin here, and this is what is called the epidural space. Now, I told you that the spinal cord comes down your back. Actually, the spinal cord stops at around L1 1. So actually it's quite high up in your back. And below that, there's just these nerves that drop down inside. And that is called the cauda equina, which for those of you who don't know the translation, literally means the horse's tail. And the reason it's called the horse's tail is because these nerves very much look like these fibers of a horse's tail. And they drop down through here and they pop out at each level. There is indeed the epidural space. This has significance from my point of view because if we are injecting into this area, it's very hard to damage the nerves if there was any issue, whereas higher up you're right at the level of the spinal cord, which is not, we can't do it, it's just a more risky injection. We're now going to talk a little bit about the discs. So the discs are made up of 2 parts. There's the annulus fibrosus, which means the fibrous ring, and the outer third of this has nerves. There's no nerves in the center of your disc. The outer third has nerves, and inside the center of this is something called the nucleus pulposus. And you will see that this very closely resembles this. Nucleus pulposus means strawberry jam, and it sits in the middle of your disc, and this is what we worry about coming out. Because once you split the disc and this jam comes out, it is very, very pro-inflammatory, and this can cause all sorts of problems both in the disc. You can get disc pain, but it can also cause problems for the nerves themselves. And we talk about discogenic pain. This is pain that comes from the discs. But in addition to that, you can have radicular pain, meaning from the nerve root, and depending on where that disc bulges and herniates, it can cause those problems. There are different levels. We don't need to bore ourselves with the actual details, but it can go from a small crack. It can really start bulging out. It can come right out, and then you can have actually parts of the disc that come away from the disc. And all this is now extremely inflammatory, so anything nearby will get inflamed, and you'll get edema in that area. You'll get pressure on the nerves. You remember this one? This is about protecting your back. This, incidentally, here is why truck drivers, long-distance truck drivers have back problems, because they maintain that posture for a long time. I'm not going to go into this one again. We're going to move on and talk a little bit about the nerves themselves. And this now shows you why a disc herniation hurts, and why somebody who's digging in their backyard, who suddenly sometimes hears a pop, and then they get the shooting pain that goes down into their leg, get that. The nerves of the cauda equina, so this is now looking straight onto the back from behind, and we've removed the back portion so you can see what's going on inside. These are the nerves of the cauda equina, the horse's tail, which comes down here. At each level, so this, for example, is L5, this is L4, and this is what we call the L4 nerve root that comes out of that point. This is the L5 nerve root that comes out of this point. If you blow your disc here and you get inflammation, you are going to have it affecting that nerve there, and it will predictably go down into your leg. If this was ruptured further out, if it was ruptured right over at this side, what some people call the far lateral disc, then this nerve might be fine, but this would now be affecting here. If it was to go straight across, then you would have multiple discs involved, and that's now getting to the region of surgical emergency, once you're getting multiple discs, one disc but multiple nerves involved. We talk about this in terms of axial back pain and radicular back pain. Axial back pain is back pain that stays in the back. Radicular back pain is back pain that goes down the leg. And all the time we're trying to differentiate between these two things. Is this something that's sitting in the back, or is it something that's sitting in the back but going into the legs? Those nerves go to very predictable places, and this is dermatome man, and we know there is variation between patients, but pretty much we know that if somebody comes in with back pain and they have pain that also goes down the knee, and they're talking about calf pain and that kind of thing, that there is a very particular nerve. The L4 nerve root is probably the one involved, and then we get an MRI and it confirms that's right, and we slap each other on the back and we say that we're very clever. But it's predictable, which is why we like it. So that's the kind of the discs and how the discs interplay with the nerves themselves. Now I'm going to talk. Ian's talked quite eloquently about the facet joints, but I'm going to just touch on them a little bit more. These are the small joints in your back that allow that flexibility. And the interesting thing from our point of view about these joints, oops, we'll come on to that one in a minute, is that they have a nerve supply that comes to them that is purely sensory. So when there's a problem with that disc, we can talk about not only when we talk about this joint, we can talk about dealing with the joint itself, but we can also talk about doing something about just the nerves that go to that space. The next slide is introduces you to, if you come to my longer, boring talk, I talk all about the history of this, which is quite a political statement to do with this. But as I'm sure you're all appreciating, what we're talking about here is the dimples of Venus. This is a picture of Venus. This is Cupid. She's admiring herself. But what we're interested about is this, which is, as Ian pointed out, that is the sacroiliac joint. This joint is a joint that causes all sorts of pain. Can be bad when people sit for long periods. When they're driving to New York, it causes a lot of pain. And that's an area that we can kind of hone down and see if there are things that we can do to take down inflammation. You'll appreciate that that joint is oriented kind of in an upright fashion. You have one on each side, and as you walk or as you stand on one leg, all your body weight from this side of your leg and all this side is now transferred through that joint. So if you have problems with that, it can be very, very hard to get comfortable. Here it is, the sacrum. The sacrum is what the Greeks believed was where your soul, so we always think of it as either in your head or your heart, but the Greeks thought of it as your soul actually dwelt in this area at the base of your spine. Here it is, it extends forward. Sometimes the pain not only radiates across the back, sometimes it radiates down through the buttock. Occasionally it radiates forward and into the front of the legs, but it does not go down below the knee as a rule. Ian talked a lot about the muscles. The muscles in your back, essentially you think you have control because you can move. Oh, I can do all these movements. I tell my muscles what to do. Well, that is a little bit of a fallacy. To be honest, these are like the Bond villain. They're the ones with the white pussycat that stroking it. They control you. It's not the other way around. These will get themselves into a position where they hold your back in its most comfortable position. Sometimes the muscle spasm itself is the problem, but more often than not, there's something going on deep down, and the muscles are reacting against that. And we end up with this kind of pain, another sort of pain cycle. You get injury and stress, you get pain, your back spasms, the spasm itself is using up oxygen, it's cutting off that blood supply, you get more pain, and you get into this problem. So sometimes the things we'll do is we will do injections into the muscle just to relax it. That has to be done really in conjunction with the work that the chiropractors and physical therapists do to free up the muscles in the back. So we'll talk now about the injections themselves. We're guided by the anatomy and the pathology of what's going on in your back. There are two things we inject. There's many different varieties, but ultimately it comes down to two things. One is a steroid, and the other is a local anesthetic. Local anesthetics work almost instantly. They depolarize the nerves. You get that horrible pain when it's injected, like when the dentist injects the same kind of thing, and then it's completely numb. Steroids take longer to work. They work right at the level of the DNA in the cell, and it takes a while for them to take an effect. It can take 5 days, it can take 10 days for that to really kick in and have an effect. We use steroids and local anesthetics in a slightly different way. The steroids are used to take down inflammation, to allow the nerves or whatever to have more space. The local anesthetic can help with some of that, but really it gives us really interesting and important diagnostic information. In other words, if I inject something with local anesthetic and 20 minutes later your pain has gone, that is very diagnostic that that is the source of your pain. It may then return, and we can talk about what we do in that situation, but from our point of view, that is what we're looking for. Did it help at that point, at that moment? One thing I do need to talk about a little bit of the side effects of steroids. They're not benign drugs. They are extraordinarily good drugs, but they're not benign. And so the question I'm commonly asked is, how many injections can I get? And I usually say, there's never been a proven safe or unsafe level. I tend to say 4 is safe in a 12-month period, but really, we look at the dosing. The patients I particularly worry about are young women because of the problem with bone density. And although they won't have a problem now, 20 years down the line, 30 years down the line, they will fall and break a wrist or a femur because they had too much steroid. So we are very careful with those, but generally periodic injections should not cause you significant health problems. So I'm going to talk about a few of the injections. The first one is the one we do so many of these in instances where patients have radicular pain. You remember that is the pain that goes down the leg. It can help with disc pain, and it can help with spinal stenosis because it frees up. It gives more space for those nerves to move down, although it does not change the anatomy. Again, we saw this before. We're going to be injecting right down here at the level of the cauda equina. This is another a picture of it, a little blown up. This is the L4 or the L5. Here's the disc in the middle. These are the nerves of the cauda equina that are coming down. We're here at the level of the skin. These are the bony bits you feel in your back, which is what I'm feeling for. And ultimately, we line it up on an X-ray, and we drop a needle into the epidural space, comes through the skin, goes right through here. We locate it with an X-ray, we get into this space, and we inject. And we try to get as close to the pathology or whatever the disc is going in your back that we can, but the truth of the matter is that medication spreads up and down, a good amount and round both sides. So often when I see patients with this is my kind of go-to. There are more precise injections that can target individual nerves, but this is my one I now go to as giving me the best chance of covering that disc and that radicular type pain. And after that, we look and see how you did with it. The facet joints, there are two approaches to this. You can inject into the joint itself. I don't do that anymore. I think you can rupture the joint capsule. You can introduce infection. I try to avoid doing that. I have occasionally done it recently, but I try to avoid it. What's interesting about these is that there are nerves that go to these joints, as I said, which are purely sensory. This is what we call a facet injection, but really it's a nerve blocking exercise. This I know is a kind of a busy slide, but I'm just going to blow up this one here because it shows really on the anatomy what we're trying to do. If we assume that the problems you're having is at the L5 onto the sacrum, that you have this inflammatory process that's going on in here, or an arthritic process that's going on in here, you'll appreciate that there is a very small nerve that drops down and goes to that joint from there, and there's another nerve that comes down from the top. What we aim to do is we aim to inject this point here and this point here to block those nerves with local anesthetic, and also we put in some steroid which calms down the inflammation that's going on in this joint. Now again, if you get good relief from a few of those, from that type of injection, it's very diagnostic to say, well, that is actually the source of your pain. And there are ways, which I'm going to talk about in a minute, and how we can do it. Sacroiliac joint, very painful joint, same kind of thing as the facet. Purely sensory nerves go to here, and we do again under X-ray. We spin the X-ray to about 25, 30 degrees, and it lines up with that joint, and we drop a needle in there, and we put steroid, and we put local anesthetic in there. And again, if you get great relief, even for a short amount of time, it is diagnostic that that is the source of your pain. Patients being patients, inevitably, it's usually coming from more than one place. And we look at the MRI, and we can't quite decide which is the main source, and we think it's probably coming from a variety of sources, but what we're trying to do is discover, is 80% coming from one place, in which case that is where we're going to concentrate our fire. I'm going to talk a little bit about nerves. I kind of touched on it a little bit, but this is again a question, because sometimes when I inject something, patients say, well, can't you just burn the nerves? Can't you just cut the nerves? Can't you do that kind of thing? And the answer to that is we can, but only in certain circumstances. There are three types of nerves. When I used to go out drinking when I was in London, at the end of the night, at this particular bar I go to, they had what they would call a bewildering selection of filled sandwiches. And these were cheese, ham, or cheese and ham, okay? So what we have here is you can have a sensory nerve, which just transmits pain and sensation. You can have a motor nerve, which does the muscles, or you can have both, all right? That's all that says. And what this says is, if it's just sensory, we can knock it out, but if it's either of the other two, we can't, because you won't be able to move that leg or something. So that's just to differentiate between those. And if we're in that situation where you get a great diagnostic block and we're doing, but it wears off, we can burn those nerves, and we use this kind of device here, which is called radiofrequency ablation. And what we do is, for either the facets or the sacroiliac is we drop 4 needles or however many needles it takes, and each one of those will predictably burn a small area around there, and that will cut those nerves. It does not last forever, but we do this if we're looking for 9 months or 12 months of relief. Nerves do actually regenerate in time, but this can be a nice, for the right patient and for the right pathology, this can be a good thing to go to. I'm going to do a few words now on something called neuromodulation. Neuromodulation essentially works on this, which this is called the gate control theory of medicine. A lot of pain and a lot of what we learn is based on this. I'm not going to go into this, just to say this. When you hit your thumb with a hammer, you rub it, okay? This is a very, very well-preserved thing throughout the animal kingdom. An animal that injures its paw, it licks its paw. It is essentially a way of putting a benign stimulus on top of a pain stimulus and masking it, okay? That's what happens. No anatomy has changed. You still hit your thumb, it's still throbbing, but some reason this reduces the pain, okay? This is what we do when we talk about about neuromodulation. There are various ones. TENS unit is another example of that. But these are the ones that we're typically doing, which involves, again, we have to have gone a long way down the road. And often these are patients that I'll see of Steve's who had surgery and have not got better. We'll consider this. This involves placing wires up inside the back. 2 leads go up inside the spine, and they sit at that area of the spinal cord where they can stimulate the spinal cord and mask pain stimulus coming up, either from the back itself or from the legs and the back. They come down, they come out to the side, and there's a little, what we call a little generator there, which can generate the pulses and the stimulation to the spinal cord, which masks that. And I'm doing more and more of these at the moment, and I think, from my point of view, we're getting some interesting, good results. And I think we have some people here who may have them in, who perhaps will talk outside. There are essentially 3 parts to it. There is the lead itself, which are these, and there's various flavors of those. There's the generator, and there's a few of those. And then there's the way in which it's controlled through the skin, and there's various. And there are different companies that are out there that do this, and we can talk about those when the time comes. The trial of that is there's essentially a 2-stage process. Okay, so implanting one of these is a 2-stage process. The first one is the one that I do. I do it in our clinic here in the hospital. And what I do is once we've done the evaluation and all the rest of it, and the approvals, we get the patient in. We essentially thread 2 of these leads up inside the patient's back, secure them in place. They then come out to the side, and they have a little controller on here, and we send the patient away then for a week, and they're closely monitored for that week, and then they determine whether it works for them or it doesn't work for them. And roughly 75% of them get good relief from those. Once that happens, they come back a week later, I remove it, we have the discussion, and if they say, yeah, I liked it, it kind of helped me, it's not going to get rid of all the pain, but it improved, I could walk further, I slept better, those kind of things, then I send an email to Steve, and I say, I've got this patient, would you mind doing the necessary? They will then come back about a month to 6 weeks later and surgically have that implanted. And the second stage is under a general anesthetic, the first stage the patient is awake, okay? The advantage of this and the pros and cons, first of all, it gives you a chance to evaluate it without going straight to surgery. So we try it for a week, and we hope it works, but if it doesn't, you avoided getting something implanted that was not necessary, or having surgery. It's not surgery, so for the right candidate who's trying to avoid surgery, that can be a good thing. It's pretty safe. We haven't had problems, but it is your back, so there are risks, but it's generally safe. We do it in the office, and potentially for patients who we have sort of run out of options, it can be a game changer. Downside, it's expensive. We need to think about the patients that it goes into. It is an implanted device, and that has some restrictions around it. There's always the risk of infection, and imaging studies. We need to kind of think about how we deal with that, so we have to pick the right patients for that. So that's kind of brought to a conclusion most of what we do. And obviously there are patients now who have not benefited from what we've done. And those are the patients that then we kind of think we've tried all these things, we've tried this, we've tried this, we've tried this, and now we've really got a point where we're looking at surgery as an option. This isn't a sequential thing. They may go straight to surgery for certain candidates. So I'm going to hand over now to Steve as we talk about kind of treating back pain, and I'll leave it there.
All right, good morning, everybody. Thank you for being here. Thank you for giving up your holiday weekend to be with us this morning. It's the first good weather we've had in months, and you're in here with us instead of outside walking the canal. I wanted to thank Ben Moor for organizing this and all of our hospital staff who really made this day happen. I kind of dropped in at the last minute to give the final talk, but these guys really put a lot of work into this morning, and we're very grateful for that. And I also wanted to thank some of our vendors who are outside with some of their equipment who, along with the hospital, helped to sponsor this. And so please check out what they have to offer after we're done with our talks. My talk this morning is about surgery. And as I was trying to decide how to frame this talk, part of it is to discuss when people may want or may need surgery. But part of it was also to dispel some myths. Every day we hear people ask the same types of questions that are sort of out there from watching daytime television or just sort of out there in the community, and maybe they used to be true and are no longer, or just came from bad medical evidence. The first myth I guess I wanted to approach, or I guess the first misconception would be better, is that some people will come to me with terrible back pain, and they've done therapy, chiropractic, injections, medications, various modalities, and they sort of come with the expectation that since their back pain is so severe and since they've tried other things, that they have to have surgery because that's all that's left. And surgery is kind of like the nuclear option for all back pain. And that's really not true. Surgery is only right for a certain subset of people. And so people can have terrible, terrible back pain that is really not surgical back pain. And I can't help with probably about 90% of the types of back pain that is out there. And a little bit of why maybe spine surgery has developed a bad rap over the years is sometimes we will try to take on people who have a terrible problem, but the surgical indications are not great, and then they don't have the greatest outcome. And so then everyone knows someone who has had back surgery and it didn't help them, or they didn't get better, they had a complication and they got worse. But what I will say is that surgery that is carefully planned, done for the right reason, and well executed, the results can be very, very good. But back pain being extremely common, surgical back pain is somewhat uncommon. What I want to talk about this morning specifically are the three most common reasons why I do surgery on the low back, which is a disc herniation, stenosis, or spondylolisthesis. A little bit about my practice. I'm in private practice. My group is called Plymouth Bay Orthopedics. We're a multi-specialty orthopedic group that operates at Beth Israel Deaconess in Plymouth. We've got offices in Duxbury and Sandwich. And I'm the spine surgeon in that group. We also have shoulders and hands and hips and knee specialists. My practice, I'm an orthopedic surgeon with additional fellowship training in spine surgery. I'm board certified. And I take care of other types of back and neck problems as well. So there are people who have trauma, spinal cord injuries. There are people who have cancer. There are people who have rheumatological conditions. And this talk is really not about them. This talk is really about sort of the more arthritic or degenerative back pain, which makes up probably about 80% of the type of back problem that I see. And the vast majority of those people who have one of these degenerative or arthritic conditions, so disc herniation, stenosis, or spondylolisthesis, the vast majority of them may benefit from surgery at some point, but typically do not need urgent surgery. So taking care of these problems is really elective, meaning it's an option, not a requirement. This isn't cancer, this isn't your heart, it's just for quality of life reasons. And in that it's elective, people deserve the chance to avoid me, meaning conservative management first, which typically starts with over-the-counter medications like anti-inflammatory, some form of physical therapy, chiropractic, or home exercises. If that's not enough, sometimes spinal injections, and then typically waiting things out a little bit to make sure that that problem is here to stay, because certain conditions such as a disc herniation, which we'll get into, sometimes the pain can be quite miserable at first, but if you can slow things down and wait a little bit, sometimes it'll get better either on its own or through conservative management. So the majority of people with these problems should have some type of conservative management, non-surgical management for at least a few weeks or potentially a few months before we start thinking about surgery. There are certain exceptions to that. So there are a very small subset of these people who need urgent surgery. And essentially what that comes down to is significant spinal cord compression causing a significant neurological deficit. So if you have a disc herniation and it's causing pain, that pain can be exquisite and miserable, but it's not an emergency. We want you to feel better, so there's some urgency in that regard, but it's not really a surgical emergency. You need some conservative management before surgery. However, if you get that disc herniation and you have bowel and bladder incontinence, or you have a foot drop, you have some significant neurological change, sometimes we would then skip over conservative management in the interest of trying to protect the nerves and restore some neurological function. Ultimately, spine surgery comes down to two main goals. The first goal is if there is nerve compression, we're trying to relieve that compression. And if there is spinal instability, then we're trying to stabilize the spine. And from here forward in the talk, what I'm sort of assuming is we're talking about people who have done the conservative management already and didn't get better. So disc herniation, you've waited 6 weeks, you tried a shot, you tried physical therapy, and it's still bothering you. So that's when we're starting to talk about an operation. But ultimately, the majority of people who end up benefiting from surgery have some form of nerve compression causing leg pain. And from the previous talks and from this slide, you can see that those nerves in your low back gather in your pelvis and go down your leg. So that's why a back problem can cause leg symptoms. This is a disc herniation. And you're seeing in the cross-sectional view here is the disc. The annulus, which is this outer part, has either ruptured or deformed, and some of that nucleus has come out, and that is contacting a nerve root. You can see it again down here. That is contacting a nerve root and can be very painful. This is an MRI of a spine. It's a pretty low quality MRI, I'd have to say. Ours are much better now. But this is the bone right here. This is a normal looking disc, which is light in the center and dark on the periphery and pretty well contained. And then this is the spinal canal. The white is spinal fluid. These dark lines, those are the nerve roots in the cauda equina. As you come down here, you can see that this disc is not like the others. So as opposed to a healthy disc, this is dark. The height has collapsed a little bit and it is bulging outward. Now, you can have disc degeneration that is minimally symptomatic. And I have to say this particular MRI probably wasn't a good choice for me to use because this is a pretty small disc herniation. You can see the nerve roots passing here are really not contacted by this nerve root. And so that brings me to another, I guess, myth or misconception, which is that people will have come in with an MRI or having seen a specialist in the past, and they've been diagnosed with either disc degeneration or bulging discs or something of that nature. And essentially, those types of problems, degenerative problems, are kind of the equivalent of developing gray hair as you age. It's just part of the aging spine, and they don't necessarily cause problems. One of my mentors did a study many years ago where they took MRIs of people who had no back symptoms at all. And the vast majority of people over the age of about 60 had something that was sort of, quote, abnormal. So it would be very uncommon to see someone in their 60s or 70s with discs that all look like this. Majority of you will have some discs that look like this, and you may not be having a problem from that disc. So having sort of, quote, bulging discs is kind of like saying I've got 2 eyes and 10 fingers. It's sort of a normal spine phenomenon as you age, and is not necessarily a problem that needs to be intervened on. That disc herniation, as the other speakers have commented on, can contact a particular nerve and cause very classic radiating leg symptoms. The most common levels to herniate are the lowest levels in the spine. That's where the most stress is. So either at L4-5 or L5-S1, and typically that affects one of these three nerves, L4, which wraps around the knee and goes to the inside of the calf, L5, which stays on the outside of the calf and then goes to the top of the foot, or S1, which tracks down the back of the leg, back of the calf, and the bottom of the foot. Those are the most commonly involved. So how do we take care of this problem? If you have a disc herniation that is causing significant nerve compression and you've waited it out for at least 6 weeks or longer, and you've tried some therapy and you've done anti-inflammatories and plus or minus an injection, the way to take that disc out, to take the pressure off the nerve, is called a microdiscectomy. A microdiscectomy is a surgical procedure. You have a small incision on your back that measures about 2 inches or so. From there, we come along the spine, gently move some of the muscle out of the way, and make a little window in the bone here. Through that window, we're able to gently move the nerves out of the way to access the disc space. And it's kind of akin to taking the pebble out of your shoe. We don't take the whole disc. You want the rest of this as that shock absorber, but just the piece that is sitting in here contacting the nerve root, we remove that. And the disc material has a consistency that's kind of like crab meat. An operation like that typically takes an hour or an hour and a half. The majority of people go home the same day. Their back's a little bit sore from the surgical incision, but the leg pain is gone because the pressure is off. And that's a fairly reliable operation for this type of a problem. Probably the most common thing that I see, and I should say the disc herniation population is usually in the 30 to 40-year-old crowd, but stenosis, as had been previously alluded to, is circumferential nerve compression. So if you look at this MRI, this is an MRI in cross-section. In this panel, imagine we're standing at your feet and slicing you like a loaf of bread. And so we're going straight down the spinal canal, and this one is a normal spinal canal. This is the intervertebral disc here, that jelly donut that can herniate sometimes. The muscles in the back are here, your skin is here, abdomen is here. The area to focus on is right here. This is the spinal canal. The white is spinal fluid. Each of these dots is a nerve root in the cauda equina. And this level is a normal level. This is what you want. It should be wide open. Stenosis means that as a result of circumferential, essentially arthritis, that canal is very narrowed. All of those nerves are crushed together. And that can happen a little bit because the disc has degenerated, and as it collapses down, it may bulge out. Also, these facet joints, those can become arthritic, and you've probably seen people with very arthritic knuckles. Their knuckle gets bigger. These can get bigger and encroach on the canal. And then there's an important ligament just to the inside of these facet joints called the ligamentum flavum, which also overgrows and causes circumferential nerve compression. And the classic symptoms of stenosis in the lumbar spine are, number one, radiating leg pain, potentially numbness, and sometimes weakness, although usually the weakness is fairly subtle in terms of ankle strength. And additionally, what are called neurogenic claudications, which is if you go to try to walk a block or so, your legs feel tired and heavy and painful and you have to sit down. And that's the shopping cart sign. You feel good when you're leaning on a shopping cart because that opens up the spinal canal so you can go to the grocery store and walk the aisles, but the minute you try to stand upright with no assistive devices, you start to get these symptoms. For stenosis, again, having failed conservative management, the surgical treatment for that is called a laminectomy. In this cartoon, your front is here, this is the disc space, here's that spinal canal, and the lamina is the very top part of the canal, or the roof of the canal. And so in a laminectomy, you've got an incision in your low back, we've gently moved the muscles out of the way, and then we've unroofed the canal. And by unroofing the canal, we're able to gently reach in and take away that arthritis that's encroaching on the nerves. Here's the same operation depicted from the surgeon's perspective, looking straight down on the spine, where you have decompressed from above to below the area of nerve compression. And sometimes this may be a one-level surgery, sometimes it can span multiple levels depending on how many levels are involved with nerve compression or stenosis. The goal of all of this is to take this very tight canal and make it look like this again, to open it up so that the nerves all have more space. And the extent of that operation really depends on how many levels need to be done. If it's one level of stenosis, that takes about an hour. Typically people stay in the hospital overnight for some pain control and go home, but sometimes it has to be multiple levels, which just adds up the surgical time and the recovery and everything. The hardest part of the recovery from this is really not related to the nerves. It's really the muscle after surgery, because we've had to come through that, separate the muscles, move them apart to do our work, and then repair everything. So it's really sort of the surgical recovery is the muscles recovering after we're done. The last surgical pathology I'm talking about is called spondylolisthesis. And this is an X-ray looking at the spine from the side. Here's an MRI, and then here's an animation, all showing the same thing. Here are the bones with the disc spaces, and you can see at this level right here, there's this step off between the back of this vertebral body and the back of this vertebral body. And that instability happens when there is degeneration within the disc space, degeneration within the facet joints. That arthritis can create some instability. Here's what it looks like on an MRI, and you can begin to appreciate why there is nerve compression at the level of that step off. The spinal canal is a tube of bone, and if you imagine that you're looking through a tube like this, and then it shifts, the nerves that are going through there would be compressed at the level of the shift. And here you can see that it's not so much behind the vertebral body, but it's really around the disc space where those nerves are trying to make the bends there and can get compressed. Now, when you have spondylolisthesis, that is instability. So having failed conservative management, the treatment for that would be first a laminectomy, just like we previously discussed. You're unroofing the spinal canal to free up those nerves. But you can't stop there, because when there's already inherent spinal instability, if you just do a laminectomy and nothing else, that instability can get worse. And if that instability gets worse, it can cause other areas of nerve compression. And so in that situation, you would do a fusion. Fusion technology has been around in some form or another for many years. Historically, it was what's called a non-instrumented fusion, where we just put down bone graft, and the biology of fusion was very similar to fracture healing, where if you fall and break your wrist, we might put that in a cast or put a plate, but ultimately your body is healing the fracture. And it's the same thing with a fusion, where we're trying to weld these two bones together by putting down bone graft that will then ultimately heal and make those two bones into one. More modern technology, in addition to bone graft, we're better at stabilizing it so it doesn't move anymore, because fracture healing and fusion healing requires stability. And so these are screws. These are called pedicle screws, and they're connected by a rod. This is, since you're looking at the spine in profile, there's actually a total of 4 screws, 2 here and 2 here. You're just seeing them overlap. And then sometimes we would also put a device in the intervertebral disc, which can also have bone graft in it to cause it to fuse, and that's called a cage. So modern fusions typically have, in addition to bone graft, they have pedicle screw instrumentation, which is this, and possibly an interbody device with bone graft in it as well. The only research that I'm going to bore you with this morning is this very important study called the SPORT trial. SPORT is an acronym for Spine Patient Outcome Research Trial. And this is, within orthopedics, within spine surgery, probably the biggest study that has ever been done. It involved 2,500 patients. There were 13 sites, 2 of which I trained at, and so these were my mentors involved in this very extensive study. And they evaluated people who had had surgery versus people who were maintained on conservative management, non-surgical management, at 2, 4, and 7 years. And there were 3 arms. One was disc herniation, the second was spondylolisthesis, and then the third was stenosis. So the 3 categories that we just talked about. And these studies were ultimately published about 10 years ago in very high-profile medical journals, the Journal of the American Medical Association and the New England Journal of Medicine. There were, arguably some technical flaws within the study in terms of how they ran their statistics, but ultimately they found that surgery for these conditions had very good long-term results. Now, I should say these were people in the surgical group who had tried conservative management at first and it wasn't working, so then they had surgery, versus people who tried conservative management and then they just stayed with conservative management as opposed to having surgery. And what they found at 2, 4, and 7 years was very good results for microdiscectomy for disc herniations, laminectomy for stenosis, and laminectomy with fusion for spondylolisthesis. And those outcomes, as we get farther and farther away from the original research, reevaluating those same patients, the results are holding long term. This is my dad and my two boys, and my dad had very bad stenosis and spondylolisthesis at L4-5-1 level. And he's kind of a tough nut, and he's an anesthesiologist, so he doesn't listen to surgeons inherently. And he tried to avoid surgery for years, but ultimately he was developing a problem where he couldn't walk very far. He had to stop and sit down. I could tell when he was playing with my kids, he was always leaning against something, sitting. And this is someone who, just like Ian, was a D1 hockey player and a superhero. And he was really getting slowed down by this, despite being otherwise very healthy, very fit. He tried the usual conservative management over the course of years because he stubbornly didn't want surgery. Ultimately ended up having an operation last summer, which went great. And this is him leaving the hospital 2 days later from a fusion, which is very fast. I couldn't believe how quickly. I just came on a Saturday morning to visit him, and he was like, "I'm fine, get me out of here." And he's had a great result. Now he's 6 or 8 months out from this thing. The initial surgical recovery wasn't much fun, but once he got past that muscle healing phase of the recovery, now he tells me he stops walking not because his leg hurts, but he stops walking because he's bored of walking so far. So he's done extremely well. I will say, though, every once in a while I get someone who comes into my office and they've got spinal instability and they would benefit from a fusion. And sometimes telling someone that they need a fusion is like telling someone that you're going to cut off their leg, because they've heard that fusions are bad, they just want a decompression, and they know someone who had a fusion and it wasn't good. And again, if you're doing fusions for the right reason, they can be done safely, they're very effective, and the outcomes are very, very good. And fusions getting a bad rap are people who are trying to cure the wrong type of back pain with back surgery. Another area that I get asked about all the time is, well, do you have a laser? What about the laser? And we don't have a laser. The reason being, there is no good scientific evidence for laser helping with any back problems at all. If any one of you ever watches daytime television in the last 10 years, you will see a commercial for the Laser Institute, but there's no real scientific evidence in support of this. As a result, your insurance doesn't cover it. And this was our North American Spine Society sort of a consensus statement about the laser. If you take nothing else from my talk, you don't have to have a fusion, but please don't do the laser. So that's a wrap for me. If there are any questions, I'll let Ben Moore moderate a question session. Thank you.
We're going to take some questions now, if we have any from the floor. I think we have a microphone somewhere. If you have a question, yeah, we'll come on in.
Do you ever use PRP or PRGF in treatment? And also the implantable modalities, do you feel numb and tingling all the time in the area where it's implanted?
So that's a good question. So the question is about the different modalities in terms of stimulating when we do a spinal cord stimulator. The answer to that is that the old stimulators, you would feel the tingling and you would feel it. The newer technologies, you don't really feel it as much. Some of them you can switch between the two, and some patients do well when they feel the stimulation at that site, and some just don't like that feeling at all. I think the technology and that part of it has moved on quite a lot, and I think there's a lot more that will be coming down the line on those things. So, you know, we particularly trial one type of device at the moment. Occasionally we use a secondary one, but at the moment, most patients benefit from the stimulation that does not cause that tingling, the more of the high frequency stuff that you're talking about.
If you had different areas, say your cervical and your lumbar, would you need 2 devices?
Yes. I mean, you can do one generator, but you need 2 devices, 2 lead placement, yes. And I will say that I don't do the cervical ones. I'm doing the lower back ones. At the moment, we're not doing cervicals. Any other questions? Yes. Is the mic?
Oh, hi. If you know that your one leg is shorter than the other, I would assume that tips your pelvis. Can that cause more pressure on your back and cause the muscles to cause pain?
Short answer, yes. Ian, do you want to talk to that?
Is that on? So that's a good question. We hear it. We have that. I think anybody who does any type of manual therapy or anybody, almost every patient says they've been told they have a leg length discrepancy. So I think the rule of thumb is that if it's truly over a half an inch, then you want to see a podiatrist and possibly consider some level of orthopedic riser
Lift
to
or something?
Thank you, to normalize the leg length. But I will say, if you look at the same person and you measure their leg length on 10 consecutive days, you can have a different leg length finding every day. It can vary on people. If you walk down the street with a crown and your right leg is on the low side and your left leg is on the high side of the crown, you'll go to bed that night with one leg longer than the other. If you walk the opposite way the next day, your pelvis will modify things a little bit. So a true leg length discrepancy needs to be addressed if it's over half an inch. But don't be too alarmed if one day one leg's a quarter of an inch off or a tenth of an inch off, something like that. The next day it might change back. So you can have a true leg length versus a physiologic versus a anatomic. Anatomic is truly a difference that needs to be addressed, versus physiologic is something that can be changed or manipulated on it with manual therapy or stretching.
Well, if you're laying down on your stomach and your chiropractor tells you that one leg is a half inch shorter than the other, is that a pretty good indication that it's always?
In those cases, yeah, you want to look to have some type of lift put in your shoe.
And would that indeed cause pain in your lower back?
Definitely, yes.
And a podiatrist would be the one that would correct this for you?
I utilize the podiatrists in our community for lifts, because they can look at, and they'll tell you, do you need to have just a lift put in your shoe versus having your shoe modified.
Okay, thank you.
I can add to that a little bit. So sometimes people will come in saying that they have a leg length discrepancy, and actually their leg lengths are equivalent and they've got significant scoliosis. And so if you're laying down and your leg lengths are perceived to be different, that may be because your spine is very tilted and your pelvis is tilted as well. And so I think I'd see that more commonly. The true leg length discrepancy greater than about 2 centimeters, that's pretty rare. But degenerative scoliosis or missed or neglected adolescent idiopathic scoliosis, we see that all the time. But also the inherent pathology of the spine, the scoliosis, that is painful in and of itself. So I guess we're sort of saying the same thing, but it's not necessarily the leg length discrepancy that's causing the pain. If there's a significant degenerative scoliosis, that can be very painful in your back as well.
What would be the traditional ways of diagnosing a sciatic damage or hurt?
First of all, sciatica means something very specific to those of us who are up here. It means nerve compression in the lumbar spine causing radiating leg pain,
Right.
possibly numbness or weakness. However, you'll definitely have people come to your office saying, I have sciatica, when they really mean I have back pain, I have SI joint dysfunction, that kind of thing. So first is a history and physical exam. Sciatica has very classic findings. It's typically radiating. The most common levels are the L4, L5, or S1 nerve root involvement, which follows a pattern that goes below your knee, potentially into your foot.
Below.
The upper lumbar nerve roots can stop at the thigh. And associated numbness and tingling. And then the way to diagnose it most precisely, at least to identify what is causing the sciatica, is an MRI.
Okay.
So sciatica is not so much a diagnosis as a symptom, but then the MRI will tell you what structural nerve compression is causing that problem.
Any more questions? We've got one down here, and then we'll come down to you, sir. So at the back.
Yes, Dr. Leckie, you mentioned during a laminectomy that you actually remove the arthritis. Do you remove tissue or what?
Right. So in a laminectomy, that spinal canal, which is a tube of bone, we're taking off the roof. And by doing that, we can then gently reach inside the canal and take away the overgrown portion of the arthritis. So the facet joints that have overgrown, we can take away a little bit of that. The ligamentum flavum, we can take a little bit of that. So that is tissue that is being removed. We can't take away all arthritis. We're not touching the disc space. It's not technically arthritis, but you can kind of think of it as a degenerative condition. We can't take that out. And we can't take away too much of the facet joint, because if we do that, we will create instability and you'll end up needing a fusion. So what we do is sort of sparingly take away the arthritis that is causing any nerve compression without creating any instability. And then the next question, which I get asked all the time, is if you have a laminectomy, aren't my nerves vulnerable because that tube of bone is there to protect them? It was put there for a reason. Is it possible that I could somehow get injured, or what covers it? And I used to worry about that myself when I was in medical school, but the reality is even in a person who's very thin, there's a thick layer of muscle and then a very thick fascial layer and then subcutaneous tissue and skin that close over top of this. So your spine is not vulnerable to injury after you've had the laminectomy, even though tissue has been removed.
Thank you.
Yes, down here.
What has helped me with my lower back pain was good posture, stretching, and hanging from a chin-up bar. And I feel that that decompresses my back, and I have no more lower back pain.
So that's a good point. Dean, do you want to talk about traction?
Yes. So patients in your state, or anybody who walks on the earth and is engaged in gravity during the day, an excellent investment for Christmas or a holiday or birthday is an inversion table. You know, and you don't want to use it alone. You don't want to have somebody in the house when you start using it. But I think 5 minutes on an inversion table, I've had more patients who are nurses or construction workers or teachers, or surgeons for that matter. Anybody standing for long periods of time who has a chronic recurrent back pain, inversion tables are a great idea. Traction, it's essentially undoes gravity, or engages gravity in a different way to what the gentleman was alluding to. Traction is one of the best things that we can do, and more importantly, we can do it at home in those situations.
And I think also to the point, the posture, the exercise, I mean, as Ian said earlier, less is more. And if you can get away with that and that works for you, that is where you should be. It's fantastic. Thank you. Yes?
If a patient had a spinal fusion and it was researched and it was deemed that it was necessary and it didn't work, and like 5 years later and he's still in a lot of pain, do you ever redo a spinal fusion, or do you revisit that area?
Yeah. Revision surgery is a big part of my practice, and it's always complicated and it's always very sort of specific to each individual case. There are a couple of reasons why an operation may not have worked the first time around, either wrong diagnosis or poor indications. Rarely is the problem that it was technically not well done. Typically it's technically well done. Another thing is sort of expectations about what that operation was supposed to do. If you had that fusion expecting to be cured of back pain, you'll probably be disappointed. But if it was addressing sciatica, hopefully the sciatica pain has gone away. And it doesn't always work. As with any medical treatment, it doesn't always work. Now, in revision surgery, there's two major categories that we're looking at if we're trying to decide if someone needs a second operation down the road. One is, did that surgery, if it was a fusion, for example, did that surgery fail to fuse? And you have continued back pain from what's called a non-union or pseudarthrosis, and that can over time become very painful. Sometimes the hardware can even break. The analogy is if you took a fork and you bent it back and forth 1,000 times, eventually that strong metal would break. It's a race between your body fusing the bones together and the hardware failing. So sometimes a non-union can result in screws loosening, and that can be painful, and that would be a reason that you revise. You go in and put in more bone graft, you put fatter, longer screws, and there's things that you can do. The other, and frankly most common reason why people have to have a second back operation is not the level that was operated on, but they'll develop breakdown of the level above or the level below, and that's called adjacent segment degeneration. You can imagine physiologically each of those levels is supposed to perform a mechanical role, and when you fuse one of those levels, that alters the biomechanics, and that puts more stress on the level above or below. And so then those can wear out and develop arthritis, develop stenosis, and develop instability. And so that's by far the most common reason why people would have revision surgery. And it's not unlike my hip and knee partners who will do a hip replacement, but those hip replacements don't necessarily last forever. The plastic wears out, and you may need a revision 15 years down the road. What I can tell most people, though, is if you're in your, maybe late 60s or beyond, the chance of needing revision surgery with sort of modern technology is pretty low. Once in a while, I'll have to do a fusion on a pretty young person, someone who's 30 or 40, because of trauma or because of they had just sort of inherent stability from spondylolisthesis. Those younger people will almost definitely have another operation at some point in their lifetime, so it's just kind of a matter of time. The other thing I will say about that is, remember, the revisions that we are taking care of now are based on technology that we had 10 years ago. And I can't prove it because it's impossible, but our technology has improved, and I think that our revisions are going to go down in the future. And the analogy is, we keep bringing up your cell phone, which is the size of your low back. Well, if you think of the technology in your cell phone 10 years ago compared to where it is now, cell phones can do so much more, and that is the same with modern technology for surgery, injections, and so forth.
One other thing, this is a sort of situation where maybe a patient would go and see Steve, and they would evaluate surgery, and maybe if surgery can be avoided, he might send them on to me. We try a spinal cord stimulator to see if that's sufficient. Obviously, each case is individual, but that, sometimes resurgery is not a great option for other reasons. For maybe the patient has other comorbidities, heart problems, and that kind of thing that makes surgery more risky. So we would work between ourselves on that sort of case. I think what we'll do is we'll take a couple more questions, and then people will have to get up and stretch their backs, and we'll head out. One more question? Anyone? Are we good? All right. All right. Well, thank you so much all for coming. Enjoy the rest of the weekend, and come and join us outside.